Atuk? Atuk? Hello? Hello?
Kecemasan, boleh saya bantu?
Tolong, atuk saya. Dia sakit dada dan sesak nafas.
Okey, bertenang, Dik. Kami akan bantu, ya. Boleh berikan saya nama dan alamat benar rumah adik?
Nama saya Anis, nombor 72, Jalan P16D, Misi 16, Putrajaya.
Adakah nombor telefon ini boleh dihubungi semula?
Ya, boleh.
Adik Anis, saya akan sambungkan adik kepada pihak hospital.
Hello Adik Anis, hospital boleh saya bantu? Ada orang dewasa di sebelah adik?
Sekejap, saya akan panggil jiran saya. Makcik, tolong.
Ha? Kenapa?
Atuk sakit dada. Tolong, makcik.
Sakit? Hello? Ya? Ya, saya jiran dia. Sekejap ya, saya ke rumah dia sekarang. Jom.
Hello Encik, boleh saya sahkan alamat lokasi kejadian Encik?
Nombor rumah 72, Jalan P16D, Precinct 16, Putrajaya.
Okey Encik, adakah nombor 0176321951 ini boleh dihubungi semula Encik?
Ya, boleh Cik.
Okey Encik, boleh nyatakan jenis kecemasan ini?
Dia sakit dada.
Anggaran umur pakcik berapa tahun Encik?
Dalam lingkungan 55 ke 60 tahun.
Mangsa masih sedar atau tidak?
Dia separa sedar dan nafasnya tercungap-cungap.
Adakah mangsa pernah mengalami serangan jantung sebelum ini?
Itu saya tak pasti, Cik.
Okey Encik, ambulans kita dah aktifkan pasukan kecemasan. Jangan letak telefon dulu, saya akan jalankan tindakan yang perlu dilakukan Encik.
Baik Cik.
Putra Medik 2 MCC Putrajaya, ambulans call over.
MCC daripada Medik 2 End Road over.
Cik, sila tukarkan telefon kepada mod pembesar suara. Letakkan sebelah tapak tangan di atas dahi pesakit dan sebelah lagi di bawah lehernya. Dongakkan kepala pesakit. Dekatkan telinga anda pada mulut pesakit. Bolehkah anda mendengar atau merasa pernafasannya?
Ya.
Adakah mangsa bernafas secara normal?
Tidak.
Cik dahulukan dengan tekanan dada. Dengar betul-betul. Saya akan ajarkan Cik cara melakukan tekanan dada. Letakkan perut tapak tangan Cik di atas tulang dada tengah, di antara dua puting dada mangsa dan sebelah lagi di atasnya. Teruskan dengan tekanan dada berulang kali. Jangan berputus asa. Rawatan Cik akan membantu meneruskan fungsi jantung pesakit sehingga bantuan paramedik tiba. Beritahu saya apabila paramedik berada di sisi mangsa atau jika berlaku sebarang perubahan.
MCC daripada Medik 2. Medik 2 membawa seorang pesakit 54 tahun lelaki Melayu dengan aduan tidak sedarkan diri. Penilaian sekarang pesakit sudah sedar dan bernafas. Pesakit akan dihantar ke zon merah.
So Tracy, what do we got coming in?
Yeah, Dr. Boyer sounds pretty sick. He's an 18-year-old motor vehicle crash victim, unrestrained driver. Sounds like he's a little unstable in the field. Heart rate is in the 120s. Blood pressure is 90/40. He's got an obvious left femur fracture. They have him in a hair traction splint. He's backboarded, collared. They have him on some oxygen. It sounds like his O2 sats are in the 88 to 93%, and his GCS is poor.
So minimally responsive, and they've got some oxygen going.
They have
and
oxygen.
one IV?
One IV, I think 18 in the right AC.
All right. So it sounds like this guy is pretty injured. We're going to need to take care of a lot of things. It sounds like he has an airway problem. It sounds like he's in shock. So a couple quick things we need to do very quickly when he gets here is let's make sure that we got our airway stuff ready to go. It sounds like you need to be intubated. So we got everything we need?
I got everything else.
All right. And Betsy, it sounds like he's only got one IV. So when he arrives, what I'd like you to do is put a second IV in on his other side that he doesn't have one. We'll get some blood out of that when we do it. Also, if you would call the lab and x-ray before he gets here, make sure they come and help us out. And Tracy, when he gets here also, I'm going to look at his airway, and while I'm doing that, can you put him on a monitor and a blood pressure cuff? And let me know immediately what the vital signs are so we can go from there. And I guess the other thing we want to think about is this guy's probably bleeding a fair amount from the sounds of it, so let's notify the blood bank, and let's get the massive transfusion protocol on standby and make sure that we got that ready to go. Also sounds like this guy is a little too sick for us to keep here. So once we figure out what's going on, let's get the trauma center on the phone because I'd like to talk to him and get him transferred, okay?
Yes, sir.
All right. Any questions?
Nope.
All right, let's do it.
This is Garrett. He's 18 years old. He's an unrestrained driver in a single vehicle MBA into a tree. About 10-minute extrication. He has a GCS of about 8. Has a head injury up here underneath the gauze and has an open femur fracture with some minor bleeding.
Is it motor vehicle collision into a tree?
Yes.
Prolonged extrication.
10 minutes.
He's unrestrained.
Unrestrained.
And you said he's got an obvious head injury.
Obvious head injury.
And an obvious femur fracture.
Open femur fracture with some
Okay.
bleeding.
And that's all you see right now.
The bruising to the left chest as well.
And his last set of vitals.
Blood pressure is 90 by Pal. He was 120 times tap on the monitor. Respiratory rate was about 12. Was clear bilaterally. And he's been unresponsive for us.
Any other issues?
Not that I know of.
All right. Thank you very much.
Thank you.
All right, guys. This guy looks like he's got a lot of injuries, and let's do this in a nice systematic fashion. We'll start with the ABCs. So Tracy, while I'm assessing the airway, I want you to put some leads on. Let's get a blood pressure. And Betsy, if you can come over here on this side and help me with the airway. Looks like he's breathing about 20 times a minute. Sir, can you open your eyes? Sir, what's your name? Looks like he's not responsive at the moment. He's got some obvious facial trauma, and it looks like he's not breathing real well. He's a little bit blue.
O2 sat 82%.
O2 sat's 82%, so we're going to need to intubate him. So what I would like you to do, Betsy, is I want you to hold C-spine precautions here. I'm going to take the C-spine collar off.
C-spine.
And I'm going to put in an oral airway in here. See if we can get a little bit better. All right, let's put this oral airway in. Let's go ahead and bag him here. Responsive. It looks like he's going to need to be intubated. Do we have our intubation stuff ready?
Everything's right behind you, ready to go.
All right. Can you bag him here while I grab that?
I got it.
Can you come off for a second? Let me just take a look here. Looks like we got a little bit of blood in there. Let me suck that out. All right.
Suction.
Suction. All right. Good. Great. All right. Let me just take a peek here.
Let me know if you want some cricoli, Dr. Boyd.
Yeah, a little cricoli pressure would be great. Thank you. All right. See his cords, tubes going in. Great.
Good color change. Good
Great.
color change.
All right, let's get him hooked up to a ventilator. In the meantime, let's put the C-spine collar back on, protect the C-spine. All right, and let me take a listen to his lungs. Betsy, there's a little bit of bleeding there. Put some pressure on that if you would.
Can we call for respiratory and a ventilator, please?
I got good breath sounds on both sides, a little bit less on the left and the right. He's got some bruising on his left chest. So let's see what we got. His airway is taken. We got him as intubated. His pulse ox has come up to 96%. What are our vital signs doing?
Looks like his heart rate's 115 and his blood pressure is 90/42.
All right. So it looks like he's a little bit in shock. We've got airway and breathing taken care of. Is he bleeding anywhere actively? So he's bleeding down here on the leg. Can we get some more help? Hey, Will, can you help us?
Yep, come on.
Dr. Boyer, would you like a second IV?
Yes, let's start a second large bore IV, and let's hang normal saline. And how much IV is hopefully? Put some pressure on that if you would, please.
Yep.
You keep bagging. Start a second IV over here, Tracy, if you would. And I think this guy's going to need some blood, so let's call the blood bank and get a massive transfusion protocol going.
Okay.
All right. So we got control of the bleeding there. Control of the bleeding there. Let me feel his pulses down here. I think his traction splint seems to be working. He's got good pulses here with some bleeding there. It looks like an open femur fracture. I don't see any obvious bleeding on his chest. His abdomen is soft. His pelvis is not stable. I think he's got a pelvic fracture, so you could have significant bleeding from there. So definitely this guy's going to need some blood, so let's make sure we get some blood products for him. In the meantime, let's expose the patient. Does that bleeding seem to be taken care of there? Did you wrap that, Will?
Yep, looks pretty good now.
All right, can you go ahead and get him exposed, take off the rest of his clothes there?
Got it.
And once we get him exposed, let's make sure we get some warm blankets to cover him back up so we don't get hypothermic. Let's do a disability exam. All right, sir, can you open your eyes?
Blood is running.
He opens his eyes to pain, that's a 2. Wasn't verbalizing, so that was a 1. Let me see if he responds to painful stimuli. Well, he's localizing, so that's a 4. It looks like he's got a significant head injury, and we're going to need to get him to a neurosurgeon. In the meantime, let's keep oxygenating him. What's his blood pressure doing now? Looks like, let's see, it's up to 105 systolic. Heart rate's down to 100. We also, I think we're going to need to wrap this pelvis with a sheet. Can you grab a sheet for me there, Will? Let's go ahead and make sure we wrap this pelvis. And we're going to need to log roll him. So we got him hooked to a ventilator.
Coming up.
All right, this is going to be on your count. You count it down for us on the count of 3.
Secure 1, 2, and 3.
All right, let me get this backboard out.
Watch the IV.
And I'm going to examine the spine here to make sure there's no step off. Feels like there's no step off here. Let's do a rectal exam. I need some jelly for that. All right. All right. He's got good rectal tone. While I've got him up here on the side, let's put the x-ray plates in to get a chest and a pelvic x-ray.
Watch the IV, sir.
All right. And let's bring it back on your count again.
Ready? 1, 2, and 3. And 1 more.
Can we call for x-ray, please? All right, we'd like a chest and a pelvis.
Yes, sir.
All right, guys, let's reassess what we've done so far. We've done our ABCs. We've got him his airway control. We've assessed his breathing. He's got good breath sounds, a little bit of diminishment on the left-hand side. We know that he has a pelvic fracture and some bleeding from an open femur fracture. We've reduced that. We've got good pulses. He's also got some bleeding from his scalp and an obvious head injury. So this guy, clearly, we need to transfer him to a trauma center. So what I'd like to do at this juncture is we'll take a look at those x-rays we shot. I want you to put an OG tube in because of concern for a head injury, and I want you to put a Foley catheter in a moment here. And then what we'll do is reassess the patient. What are his vital signs right now?
Currently, his O2 sat is 96%. His blood pressure is 110/64. Heart rate is 97.
And we've given him how much fluids?
500 cc's of saline and 1 unit of Pax, 2 units Paxil.
2 units Paxil and a 500 cc saline. So it sounds like we've stabilized him a little bit. We've got a sheet around his pelvis here. We're going to get him packaged up for the trauma center. So Betsy, could you get the trauma center on the phone for me? I need to talk to them and arrange transport. And while we're doing that, we're going to do a detailed secondary survey. We're going to do a head-to-toe, fingers and tubes in every orifice exam. And we'll get him all packaged up to go. And also, Betsy, could you make sure that the x-ray department makes copies of all of our x-rays so we can send them along? Tracy, it looks like we've got our x-rays back. We got a chest here. Looks like he's got some rib fractures here on the left side and some haziness. He's probably got a pulmonary contusion. And his pelvic film, he's got an acetabular fracture, a pelvic fracture. That confirms, I think, what we think is going on with his blood loss. Let's get copies of these x-rays made and send them so we can send them on to the next hospital with him, okay? Dr. Brazell, hi. This is Mark Boyer from Mary, Washington. I got a patient.
Saya Dr. Asri Rangga dari Jabatan Kardiologi Hospital Sedang, Kementerian Kesihatan Malaysia. Hari ini saya akan beritahu sedikit tentang fungsi jantung, masalah jantung, penyakit gejala dan cara rawatan dan mencegah penyakit jantung. Okay. Jantung ni merupakan salah satu organ di dalam badan yang amat penting. Fungsi jantung adalah untuk menerima darah yang tidak beroksigen dan mengepamnya ke dalam paru-paru dan seterusnya mengepam darah yang beroksigen ke seluruh tubuh. Dan saya akan tunjukkan model jantung ni. Ini adalah jantung manusia. Dan di atas permukaan jantung, pada sebelah kanan ada satu saluran yang warna merah dan sebelah kiri ada dua saluran. Ada setengah penyakit yang saya akan maklumkan nanti yang boleh melibatkan saluran-saluran ni. Tapi untuk memahami fungsi, bila kita buka jantung, ini merupakan jantung sebelah kanan. Dan ini merupakan atrium di mana darah akan dipam ke dalam jantung. Dan ini ventricle sebelah kanan. Ini merupakan injap tricuspid. Dan dari sini darah akan dipam ke dalam paru-paru. Dan dari paru-paru seterusnya, darah akan dipam pula ke jantung sebelah kiri, ke atrium sebelah kiri dan melalui injap mitral dan akan masuk ke ventricle kiri. Dari ventricle ni, dia akan dipam ke seluruh tubuh melalui satu lagi injap di sini iaitu injap aortic yang juga merupakan satu injap yang amat penting, dan ini adalah saluran aorta yang besar dan seterusnya ke seluruh tubuh. Penyakit-penyakit jantung ada banyak jenis penyakit. Ada yang boleh melibatkan bayi, kanak-kanak dan seterusnya kepada yang dewasa. Dan penyakit jantung ni boleh melibatkan saluran darah jantung, otot jantung, injap jantung dan sebagainya. Dan ada setengah penyakit seperti kencing manis, darah tinggi dan tahap kolesterol yang tinggi yang juga dapat menyumbang kepada penyakit jantung. Salah satu daripada penyakit yang sering melibatkan jantung ialah serangan jantung atau heart attack. Ia boleh berlaku bila terdapat sumbatan pada salur darah di atas permukaan jantung. Di atas permukaan jantung ada 3 saluran darah yang penting. Di sebelah kanan ada 1 dan ada 2 saluran darah di sebelah kiri. Dan bila berlaku sumbatan di dalam saluran darah tersebut disebabkan oleh pemecahan pada plak kolesterol, ini menyebabkan terbentuknya darah beku. Dan bila ada darah beku, darah tidak dapat mengalir dan ini menyebabkan kekurangan oksigen pada otot jantung atau myokardium. Dan bila ini berlaku, seseorang pesakit akan merasa sakit yang amat sangat. Dan ini adalah antara gejala utama yang kita sering baca-baca atau lihat di dalam televisyen. Selain daripada sakit dada, antara simptom-simptom atau gejala lain adalah sesak nafas yang amat teruk. Yang nombor 2, berpeluh. Nombor 3, sakit dada ni dapat merebak ke tangan kiri. Dan keempat, ada kala seseorang tu dapat pingsan. Dan jika tidak menerima rawatan kecemasan, ada kala ini boleh menyebabkan maut. Antara punca-punca penyakit jantung adalah gaya hidup yang kurang sihat. Dan antara yang utama ialah cara pemakanan yang kurang elok. Kalau kita makan makanan fast food, makanan tinggi kolesterol dan kandungan garam yang tinggi serta gula yang tinggi, ini secara langsung atau tidak langsung akan menyebabkan pembentukan plak kolesterol di dalam saluran darah. Antara faktor lain yang menyebabkan masalah penyakit jantung adalah yang antara utamanya adalah merokok. Merokok mengandungi asap yang ada bahan kimia atau karsinogenik yang boleh ada kala menyebabkan penebalan pada saluran darah jantung. Antara faktor lain adalah stres, faktor genetik dan kurang aktiviti fizikal.
So let's look at some clinical examples of ST elevation. And here on the rhythm strip, which is looking at lead 2, it certainly looks like there's something abnormal. And we look down, and here we see on leads 2 and 3, there's clear ST elevation. So looking at lead 2, the isoelectric line is across there. I think we can see that there's elevation between the S and the T. And it's the same, even more pronounced in fact, in lead 3. Clear ST elevation in lead 3. And looking down towards AVF, again on AVF we can see clear, pronounced ST elevation. That this patient has had an ST elevation myocardial infarction. We can see reciprocal changes here. Here there's some depression, maybe it's more obvious on AVL. I think you can see there's depression below the isoelectric line there. These are the expected reciprocal changes. But the key thing to notice, the diagnostic feature here, is we've got clear ST elevation on 2, 3 and AVF. This is an ST elevation myocardial infarction and will need emergency treatment accordingly. And if you've got some experience in reading ECGs, you'll realise that 2, 3 and AVF indicates an inferior myocardial infarction. Well, on this one we notice that there's ST elevation here. There's the baseline, very obvious and pronounced ST elevation on V2 and on V3, on V4 and V5. This is an obvious ST elevation myocardial infarction. It's a STEMI, and these are on the anterior leads, so this is an anterior ST elevation myocardial infarction. Well, in lead 1 we're looking at some reciprocal changes, but we see pronounced elevation in 2 and 3 and again in AVF. And 2, 3 and AVF indicate infarction. But looking across to V4, we also see some elevation in V4, some ST elevation in V5, and some ST elevation in V6. So there's no doubt we've got ST elevation here in quite a few leads, indicating an extensive myocardial infarction. It's an ST elevation myocardial infarction, and it's affecting the inferior leads and the lateral leads. This is an infralateral ST elevation myocardial infarction.
Like any other living tissue, Heart muscles need blood and oxygen supply for their normal functioning. The blood vessels that supply blood and oxygen to the heart muscles are known as coronary arteries. Cholesterol deposition on the wall of this artery is called plaque. Formation of plaque in the blood vessels causes narrowing of the blood vessels. This can affect one or more arteries. When the arteries get narrowed, they are not able to supply adequate amount of blood and oxygen to the pumping heart. This lack of oxygen in the heart muscle causes chest pain or angina. When arteries are narrowed in excess, or when a blood clot forms on the plaque, the artery may become completely blocked, causing death of a part of the heart's muscles. This is known as a heart attack. What is coronary angiography? An angiography is a reliable procedure to detect the narrowing of blood vessels. It is an X-ray visualization of the heart's blood vessels. During an angiography, a flexible tube called a catheter is inserted through the blood vessel of the thigh or the arm towards the blocked segment of the heart artery. A dye is injected through the catheter so that X-ray images of the heart's blood vessels can be obtained. If the angiography does not show a blockage, the patient is allowed to go home after the test is complete. However, if the angiography shows blockage, the doctor may perform a coronary angioplasty after visualizing the details of the block. What is coronary angioplasty? Coronary angioplasty is a medical procedure which opens up blocked blood vessels, thereby restoring blood flow to the heart's muscles. Coronary angioplasty may be needed to reduce chest pain caused by reduced blood flow to the heart's muscles, minimize damage to heart muscle from a heart attack. This procedure is sometimes done as an emergency procedure after an angina or heart attack. Preparation before a coronary angioplasty. Follow the instructions regarding the intake of medications as directed by your doctor. In preparation for the coronary angioplasty, your doctor may stop or adjust the doses of the regular medications several days prior to or on the day of the procedure. Be sure to tell your doctor if you have had any allergic reaction to any substance or drug, or have any history of bleeding problems. Pre-procedure tests like chest X-ray, ECG, blood examination are scheduled before the procedure. You will be asked to sign several consent forms stating that you understand the procedure and are ready to comply with the medical team for the same. What can you expect during the procedure? The patient is relaxed with a mild sedative before the procedure. The area from where the procedure will be started, usually the thigh or the arm, is shaved to remove hair and prevent infection. The area is cleaned with a special antibacterial agent and covered with sterile drapes to prevent infection. A numbing medication, local anesthetic, is injected into the skin over the blood vessel of the thigh or the arm. This may feel like a mild sting, which lasts only a few seconds and will keep the area pain-free. The blood vessel is punctured with a needle and a thin guide wire is inserted into the artery and advanced towards the blocked segment of the coronary artery. Then, a long, thin plastic tube called a catheter is passed over the guide wire towards the blocked segment of the coronary artery. A deflated balloon is placed at the tip of the catheter. After the tip of the catheter reaches the blocked segment of the heart artery, the balloon is inflated. With the inflation of the balloon, the plaque is flattened and the blood vessel is opened up. The balloon is then deflated and removed. When the catheter is removed after the procedure, pressure is applied at the site of the catheter insertion to ensure there is no bleeding. After the angioplasty, there is a risk that an artery will become blocked or narrow again at the same site. In order to keep the blood vessels open, doctors use a device called a stent. What is a stent? A stent is a tiny, slender, expandable metal tube that fits inside a blood vessel once the blood vessel has been widened. To insert a stent, the doctor removes the angioplasty balloon catheter and inserts a new catheter on which a closed stent surrounds a deflated balloon. The stent-carrying catheter is advanced through the artery to the site of the blockage. The balloon is inflated, causing the stent to expand and fit on the inside of the artery. The balloon is then deflated and the catheter withdrawn, leaving the stent in place. The stent is left in the blood vessel permanently to keep it from closing up again. What can you expect after the procedure? After the procedure, the instructions regarding the medications, care of the wound site, resumption of physical activities, etc., given by the medical team should be understood and followed carefully.
Angina is most often a symptom of a heart problem called coronary heart disease or coronary artery disease. Your heart pumps oxygen-rich blood to all parts of your body. Your heart needs a steady supply of oxygen to do its job. Coronary arteries bring oxygen-rich blood to your heart. These important blood vessels are located on the surface of your heart. In a healthy heart, blood flows freely through the coronary arteries. The blood brings oxygen to the heart so it can work properly. In coronary heart disease, the coronary arteries become stiff and narrow, so less blood and oxygen flow to your heart. After exercise or emotional stress, low blood flow can lead to angina, pain or discomfort in the chest, arm, shoulder, neck, back, or jaw. Angina that keeps coming back over time is called chronic stable angina. It is most often relieved by rest or nitroglycerin. A clot in a coronary artery can severely lower blood flow. This can lead to more severe angina that may come on at rest and does not go away with rest or nitroglycerin. This is called unstable angina, which requires immediate medical attention. In summary, when blood flow is reduced, your heart does not get as much oxygen as it needs. This lack of oxygen is what causes the pain and discomfort of angina. If you have coronary heart disease, angina is the way your heart tells you it needs more oxygen. Talk with your cardiologist if you have questions about angina.